Gopi will give you a small introduction and then we'll probably start. Yeah, thank you.
Okay, thanks.
Good morning, everyone, and thank you so much for joining in another Acchutha's Inspire series. And today we have Dr. Sheela Kumaran, who is a very renowned, like budding researcher, I would say, who was my mentor at Elite School of Optometry way back 10 years back. And to before I hand over the session to Dr. Sheela, a quick introduction about our speaker. She did her bachelor's and master's from Elite School of Optometry and PhD from in public health, Flinders University, Australia. She's driven by a vision to improve quality of life for individuals with eye diseases and visual impairment by her research focus understanding the patient-reported impact on eye conditions and co-designing of interventions and eye models for the eye care community, basically focused on patient-centered outcome measures. Having expertise in these, she also collaborates with multidisciplinary teams nationally and internationally on various eye health and health-related programs to implement science and research projects. She's a member of Australian Evaluation Society, the International Society for Quality of Life, and the Vision 2020 Australian and Participation Committee. And currently, she's working as a research fellow and lecturer at School of Optometry and Vision Science, Faculty of Medicine and Health, UNSW Sydney. Without much delay, I hand over the screen time to Dr. Sheela. Thank you so much for agreeing and being a part of our InSpace series. Over to you, Dr. Sheela.
Thanks, Gopi, and thanks, Saranya and the team for inviting me. It's a real pleasure to be here and deliver a talk to my group here in India, like after quite some time. So I'm really excited about that. And I realized from Gopi that this is a new topic for a lot of you guys. And I think it's gaining recognition internationally, and we should catch up as well in India. And I think this is a great opportunity to, get more. Okay, can you hear me better now?
Yeah,
Hope
you're
so.
audible and clear. Yeah.
Okay. Yeah. So I just hope this session enlightens you guys to do more of consumer involvement and co-design in the research and the practice settings. Okay, so let me keep. Okay, so that's a brief career snapshot. Like Gopi mentioned, I did my optometry back in India and then did my PhD at Flinders University. And now I'm a research fellow at UNSW Sydney, having worked here for more than 4 years now. And I work in the health system space. I'm a patient-reported outcome measures researcher as well as a health systems, health services researcher. So everything I do is patient-centered, and all I try to do is incorporate patient voices in everything I do. So whatever we are doing is reflective of the needs of the patients, and then we are able to make a meaningful difference in whatever we achieve for the patients themselves. So I collaborate with several universities nationally and internationally on several health systems and outcomes project, and I also am a member of key bodies like Gopi mentioned in the introduction. So I just wanted to share this career snapshot because then you will understand the perspective from where I'm coming. Although I'm involved in several different research projects throughout nationally and internationally, I think I come from a very patient perspective, and that's why my topic today is also resonating with that. And it's all about consumer and community involvement in research. So that's an overview of today's presentation. So the first half of today's talk, I'll be focusing on consumer and community involvement. And in the later half, I'll talk a little bit about co-design, and then I'll present to you an example of a co-design project that I recently completed. So even before I start the presentation, I want to acknowledge all these different government agencies and information out there in the Australian, world and research world, and these agencies have put together really very insightful consumer involvement in co-design tools and toolkits and resources that could be used by anyone literally. And so in today's presentation, I'll be referring to a lot from those resources put together by these agencies here. And also wanted to start with some key terms, because consumer could mean different things to different people. So let's start with consumer. So consumer refers to anyone who is directly or indirectly making use of a health service or a health appointment, health system. A consumer representative is a member of a committee, a steering group, or a similar body who voices the consumer perspective. A carer is someone who is a family or friend providing unpaid care to a person with a health problem. And community refers to a larger group of people who are sharing a common interest, but they might not necessarily be from a same geographical location, but then they are within the same, group of interest. And stakeholder is an individual or group from within or outside the organization who has a key interest in the research. They might not be an end user, but they have interest in the research that is being done. Also, I wanted to highlight that different countries use different terms. Like in the UK, they call consumer and community involvement as patient and public involvement, PPI. And I think in the US, they often use the word patient engagement for consumer. There's a lot of debate on which term is a better one. But for today's presentation from an Australian perspective, I'm going to go with consumer and community involvement. So I have a few questions for you spread it across the presentation. So this is my first question here. If you have a phone, if you can scan the QR code, I just wanted to get a glimpse of how many of you here in today's talk has any experience with consumer involvement in health research context. You can say yes or no. If you can scan that and answer, please. Is that working?
It is working. Yeah, it is working.
It's working? Okay. Because I can't see any responses. Have you casted your vote?
Yes, actually, I think 6 of them have already polled
Oh
their
yeah,
votes.
voted. Why it's not showing?
I think we need to allow the participants to view the. Yeah, I can see it now.
Okay, so
You've got an overwhelming 100% no answer, Sheela.
Okay,
So it's a good thing you're talking about something which is new and important to all of us.
That's right. Now, I was hoping if there are a few people who have, then they will be able to share the experiences as well, like when we actually have a discussion. But that's fine.
You've actually got 11% now saying they have. So probably a couple of them at least would have done it. So
yeah, and I think I think it's more to do with the jargon. I'm sure people would have done some level of consumer and community involvement if they have done research, but like in varying levels. And I think that would become clear as we go through today's presentation, and then they will be able to reflect. And maybe if I ask this question next time, their answer would change, I hope. Okay, so I'm just going to move on for the sake of time. So starting with what is community and consumer involvement. So CCI is, nothing but an active partnership between researchers and health professionals and end users. Actually, this term is kind of used interchangeably with consumer engagement, but we will see like different levels of consumer involvement, and you would be able to see that the lower two levels refer to consumer engagement, and the higher as we go with the deeper we go with the engagement, it becomes involvement. And basically, when we talk about involvement, it is research carried out with or by consumers and community members rather than to or about or for them. And I also wanted to highlight this. Nothing about us without us. So this was a phrase that started with the disability rights activists in the US. This was coined by the disability activists, meaning that no policies should be made without the people they actually affect. So ever since that, health consumers everywhere have adopted it, and there is a lot of push for it in the health system. And the consumer in health actually came after the term consumer in health actually came after the civil rights movement, which was led by mental health survivors in the 60s and 70s. So these people fought to be treated with respect, to have better care, and to be actually heard. So in health research, this phrase actually highlights that people impacted by the research should actually have a say in what gets to be researched or studied and how it is studied. So that's a brief introduction about consumer and community involvement, and I'm gonna pitch in and say like why it is important. So research has shown that billions of dollars of money are wasted annually in health research, which actually fails to create meaningful benefits to patients. And we also know that one of the many reasons for research waste is that research often focuses on questions and outcomes that are of limited importance to end users. So can we do something about it? Definitely, yes, we can do something. We can incorporate their voices in everything that we do and make sure that the research that we do are relevant and meaningful from the consumer's perspective. And that's the whole point of consumer and community involvement. So consumer and community involvement, CCI, is gaining importance internationally, and it's like a big thing here in Australia as well, and that we can't even submit grant applications, like funding applications for research projects, without suitable, appropriate consumer and community involvement. So what are the benefits of CCI? So when we do CCI, I've touched on some of these things already, but to go over them again, research becomes more relevant and informed when it is actually informed by the community needs and the lived experiences. And doing CCI will definitely enhance the quality of research, and there is evidence to show that, and I'm happy to share papers if you're interested. It boosts, like when you involve consumers in the research, right from the initiation to different stages, it actually boosts the public's confidence in the research findings, and then leads to better uptake and better translation into policy. It also, when you have more of these consumers in your research team, I would talk about how you can engage consumers a bit later, but just for the benefits, if the more consumers and you are engaging within your research team, it actually increases, it boosts your recruitment and retention rates in research studies. It also empowers the consumers and community members because they are involved in the process. They get something out of it. And that's also one of the main principles of consumer and community involvement. And it encourages openness and transparencies in how public funds are used, because a lot of research nowadays are funded by taxpayers' money. And we are accountable and open and openness and transparency in that regard is really important. And like I said, it is often required by funding bodies nowadays, and also ethics committees. So how can consumer and community involvement enhance research? I mentioned in the previous slide that they actually improve the quality of the research. So these are some ways in which they can actually improve research quality. Because consumers come with the different perspectives to researchers, and they actually sit on when these funding bodies come up with like the priorities for funding, they often consult with consumers to come up with the priorities that they need to fund, and actually that increases the relevance and impact of the research that they are funding. Yeah, like I mentioned, it actually helps in identifying the measures, the research outcome measures that are important from a consumer perspective rather than just the researcher perspective. And I could actually give you some examples from my work. Um, so we were working together with an NGO called Macular Disease Foundation Australia, which is a peak membership-based organization for people with macular disease. And we were trying to do a social impact study, trying to understand what's the social impacts of people with macular disease. And we were trying to, we consulted consumers who are volunteers of MDFA with lived experiences of AMD, macular disease. And we were having all these ideas in our mind, but then when we went and when we spoke with them, actually this was right after COVID, and something that we were all doing during COVID was COVID-related research, and we were trying to, among other things that we wanted to explore in the social impact study, we wanted to also understand the impact of COVID. And it was, I think, 21 or 22, and the response that we got from the consumers were like, no, we're done with COVID, please don't ask us questions about COVID, so we don't want to be researched on that. So we ended up removing those, like we went with what they said. We removed all those questions from the survey, and went ahead and did what was actually important and relevant, and from their perspective. So that was just one example. I'm thinking if I can think of other examples. Even the final, ensuring that the research measures, the outcome measures are patient-centered. All my research for so many years now has been into developing patient-reported outcome measures. And as we know, patient-reported outcome measures are developed from patients, but should be developed from patients' perspective. Sometimes it's not, but ideally it should be developed from patients' perspectives, and I have dedicated so much of my time in getting that right. And often it's surprising to see how the quality of life impacts of patients are really different from what we think their impacts are. So so consumer involvement can definitely enhance research quality, and that's the paper I was talking about, which has some evidence on how consumer engagement can improve policy, research, and health services. Okay, so there are different levels of consumer involvement in research, like I mentioned. So it's like in 5 stages approximately. So the one at the bottom is the inform. And then you go on to consult, collaborate, co-design, and finally empower. So I'm not going to spend a lot of time on this slide because I'm going to go over each of them separately, but you can see the levels of engagement is pictorially represented. So maybe I'll just move on to the next slide. So this is level 1, which is informed, when where consumers are actually informed about the research. They just kept informed, kept in the loop about it. So information can reach to them via websites, videos, public talks, radios, information on social media, and so on. And what could this look like? So this is an example. Ria is a young woman who lives with retinitis pigmentosa and finds out new gene therapy trial on a researcher website. So something like that, like it's not a high level of engagement. It's like really basic. And level 2 is consulted. Consumers are invited to a community conversation, a focus group, or to provide feedback on the design of a survey. So what could this look like? Ravi lives with dry eyes. He shares his experience of living with dry eyes to be incorporated in a quality of life survey. So this is similar to an example that I provided in developing patient-reported outcome measures based on consultations with patients. So researchers offer information about a research study or plan to consumers, and then they usually seek their view about it. So they basically consulted, the consumers are consulted at this stage. The researchers may not actually take all the advice that they receive, like all their views on board, but they usually take what they can and provide feedback to the consumers in response to what the feedback was. So that's the basic consultation stage. It's the level 2. So level 3 is when researchers actually seek the advice of consumers or community members. An example, how can we recruit participants, or how can we disseminate results, and so on. So consumers and community members can be invited to comment on documents, be on advisory boards or forums, take part in conversations, and actually advise the research team on the research process. And how this could look like. Ruby is a carer of a partner with dementia and dual sensory loss. That's both vision and hearing loss. She attends bi-monthly meetings with consumers and researchers to explore priorities for people living with dementia and their care partners. So that's more, like at an advisory level. So, and then level 4 is equal partnership. So in this level, researchers actually work in partnership with consumers and community members to plan the research and disseminate the findings of the research. So community, again, the consumers or community members can be are part of the research team in this level. They are actually equal partners with the research team, and they are in the consumer advisory committee or a steering committee, but they share power with the research team, and they are able to make decisions just like how the researcher would be able to make decisions. So it's a shared partnership, a shared decision making, and they together with the researcher undertake the research as well as oversee the research and plan the dissemination, do the funding, everything. So they are like equal partners with the research. And you can see an example here. Jim lives with vision impairment and is a living experience researcher in a research project on bioptic telescopes. He's a paid member of the research team. He attends the weekly team meetings. He's trained to do the research just like the researchers, and he also does perform data analysis with the researchers, and he's co-author on research papers and conference papers. So that's level 4. And then level 5, which is the topmost level, is the consumer-led research, where it's so level 5 is also called Empower. So this is when consumers and community members identify a need for something, and they set the research agenda, and then they undertake research themselves, or they partner with other researchers, often researchers, in a team, right? So they could come up with the agenda, lead the research, but then they might partner with other researchers or commission researchers to do this work on their behalf. So this is this how this could look like. So Con and Mia live with kidney disease. They're working on a research study exploring the benefits of exercise to manage fatigue. So they are employed and paid researchers with lived experiences, and they actually lead and conduct the research. So that's how this level of engagement would look like. So I actually had another question on Slido now. I know a lot of people, you said like you didn't use consumers, you didn't engage with consumers in research, but now I think there might be some level of engagement that you had experienced in your research career, or the research that you're currently doing as students. So can you scan the QR code and answer the question, and let's see if we get some responses. That's great. Two responses. Oops. Few more seconds. Okay, so that's good. So and that's not surprising because that's what we've been traditionally doing. We inform, we consult, but we hardly collaborate, co-design, or empower. Actually, inform should come first. I don't know why it swapped. So I think it's moving, right? It could be moving based on the responses. So yeah, so that's really not surprising. And I think after this presentation, you would be more encouraged to do deeper consumer and community involvement in terms of collaboration and co-designing, and have meaningful collaborations. So I'm going to move on and just reflecting on that ladder that we were talking about, inform, consult, advise, co-design or partner, and empower. So this ladder of consumer and community involvement is not a literal hierarchy. Different levels may suit different research contexts. So it doesn't mean that if you're only consulted or informed, it's a bad thing. So it could actually vary depending on the research that you're doing and the context in which you're researching, the population that you're researching, and so on. So not all research tracks are appropriate for all levels of consumer and community involvement. And sometimes, like if you have to do co-design, for example, it is really time intensive and resource intensive. So it also depends on the amount of resources and time you have. But just being clear about the intended level of involvement actually helps keep transparency between you and the consumers and honest engagement. So the consumers, even when they are just consulted, they actually feel valued. And the levels and the levels of the involvement can vary over time. In the same research project, you would maybe start with informing and then consulting, but then over the period of time you might come up a problem might rise up, and then you think that you need more of the consumer input, and then the level of consumer involvement can change over time. But it's always helpful to think and plan about this early on and get those connections, build those relationships, and have those consumers on board as early as possible. So their perspectives are involved right from the start till the very end of the research project. So when to engage. So I know I've been talking about this partly here and there, but it should we just engage with consumers at the very beginning, or should we engage with the consumers after the study is done and we've got the results, and now we have to disseminate to the consumers back, the end users? So I think we have to engage. We can engage and we should engage whenever possible throughout the research cycle. So the research cycle is from deciding what you want to research, deciding how to do it, actually doing it, executing the research, doing the analysis, getting the, understanding the results, interpreting it, and then disseminating it back to the end users and policymakers, and then deciding what to do next. So that's basically the research cycle, and you can engage with consumers at any level in all of the stages of the research cycle. So onto the right side, you can see some of the ways you can actually engage with consumers at different stages. I'm not going into the details, but you can have a look at the end. But when you have this recording on the slide shared, but I wanted to say, do not underestimate the power of consumers. Like we researchers tend to think that we are literally overqualified, we know how to do things, and we underestimate the power of lived experiences. But they have a while we have the research expertise, they actually have the expertise of the lived experience, and that's so powerful. And when these two expertise join together, we will be like doing powerful research and generating some powerful outcomes and outputs. Um, So that's another question. This is kind of a word cloud. Can you type in like you? I know you have like from the previous poll, you mentioned that you do consultation and you have engaged at an information stage. But what's stopping you from collaborating more? What are some of the challenges you have faced with consumer engagement? Is there anything that comes to your mind? Even if you have not done consumer engagement in the past, when you think about engaging with consumers, what do you think could be potential challenges? That's interesting. Um, yeah. So that's pretty consistent. So it's about explaining the research question or why we're doing this research and getting consumers on board. Um, and Yeah, and investigate a bias that the investigator researcher thinks that their contribution may not be beneficial or they might not be able to contribute at all. And also, identifying potential consumers could be difficult. So that's good that you've thought about these things, and these are real challenges. Um, yeah, they tend to assume that we're supposed to do it for our benefit. I wonder why they think that. Maybe because we do the research that we think is important and not, set the priority from their perspective. So I think some of these points touches on stuff that I was talking initially about setting the research priority and getting their engagement right at the beginning to actually test out what we think is important from their perspective for actually researching. So I actually have some challenges and opportunities, some barriers and enablers that have been identified in the literature. And I think most of these things have been identified in the literature, and some potential solutions have been suggested. So let's just quickly go over them. I'm not going into great details, but finding consumers and partners is a big problem. Partner consumers are, like they have their lives, they have their day-to-day jobs. We researchers have a researcher job, but then they have their family and other jobs, and engaging with them at an information level or a consultation level is kind of easier. But as you go deeper in the involvement, it gets actually harder because of their time commitments and their willingness to to involve with the research team in a longer term commitment. So developing partnerships with consumer groups has been identified as a really good starting point. There are several consumer groups, consumer bodies like the Macular Disease Foundation Australia that I mentioned for people with macular disease. There's also Health Consumer Australia, where all these different consumers and users who are interested in health research can register. I wonder if what's like that in India, that the consumer bodies, consumer groups, or even like hospital networks that you could partner with to identify the right consumers to take part to bring on board as part of your research team or collaborative initiative. So the second important challenge is actually time pressure. Like I said, there's often like competing priorities. So when we do the research protocols, it is important that we allocate time. For example, if you have a consumer advisory committee, you should allocate time to meet, like bi-monthly or whatever is the planned mode of engagement. You have to put that time into your research protocols. And also, I think I had somewhere about including budget for that as well. So consumers, they have to be remunerated at a particular level. So in Australia, we have NHMRC, the National Medical Research Council guidelines for how much we should remunerate consumers based on their level of engagement. So that is really important to allocate that budget into your research proposals as well. And then the other challenges are just not, again, like tokenism, just doing it for the sake of doing. That will definitely not work. We have to take time to engage and build relationships. And sometimes, like grant opportunities come and we wouldn't see that coming. But if you had this research question in mind, and if you had already built that connection and started those conversations with consumers earlier on, then it is easier for you to, like in a quick turnaround, it's easier for you to bring them on board on that grant application and so on. And then there is establishing a shared vision is a problem. Like you might go from your perspective and they will come from their perspective. And sometimes there is like unintended group conflicts and this group dynamics, power issues, which I think I also have in the next slide. So having a written formal terms of reference. This is what we're going to do, like agreed terms of reference that is co-developed with the consumers can be very helpful in sorting out, like expectations right from the beginning. So, and also, like I mentioned, it is really important that we have to, so nobody is more or less, they're all equal if in a partnership. So valuing that lived experiences of consumers. So there's definitely logistical and practical issues. So sometimes I would have to meet consumers late in the night because that's the time that suits them. So like we have to work around our priorities, and when consumers are really invested in your research, you would be able to work things out. But open and transparent communication is really important to overcome the practical barriers. And sometimes the organization you're working in is not very keen, and they're not supportive, and then you can't like actually go ahead and collaborate or co-design with consumers. You can't engage. It's very hard to engage in that level if you don't have organizational support. So it is important to actually advocate the importance of CCI to your organization and develop a framework that suits the organization needs. And like I said, lack of resources and funding is a big thing as well. And we should be able to include that in funding proposal and budget. I think I might have covered some of the challenges that you have raised in the poll, but then at the end, we could always go back and see if during our discussion, we can see if there's something missing. Okay. I think I'm a bit slow on time. Okay, so if you're planning a consumer and community involvement in your research, you should be asking these three questions. What is your intention for CCI? Why do you want to involve consumers in your research? And once you've answered that, you need to figure out what stages of the research cycle would you be able to involve your consumers, and what level of participation are you aiming for? So based on your answers to these three questions, a lot of things will actually change. So this is about the evaluation of CCI, the consumer and community involvement evaluation. Actually, there's like several tools in development. So this is just one of the many tools that's online. So there's tools to assess the like the researchers and consumers expectations. There's tools to reflect during the course of the actual research project, to stop and reflect how well we are doing with our consumer involvement. There's feedback surveys like the one I have put on this slide. So this is like simple ways of measuring the involvement of consumers of each party. The reason I put this here is some of you have asked this question about how we can evaluate consumer and community involvement in research. So it is a complex, it's a presentation by itself, but then I think this will give you just a basic idea of how you can possibly evaluate. And I think it has to be a continuous monitoring and evaluating process, and not just, like at the very end when you're not able to actually change anything. And then there are guidelines to report consumer and community involvement in research. So this group 2 is there is a long form as well as a short form. So this gives you some guidelines on if you're reporting CCI in a publication, what needs to be in there to report it adequately. So that brings me to the end of the consumer and community involvement. And the next topic I'm going to go on, continue, is co-design. So like I said, co-design is the fourth level that we were talking about, where the consumers are equal partners with the researchers in, and they are designing they actually identify the problem together and designing solutions together to improve the health services by listening, learning, and making decisions together. So where it fits in the ladder, so like I mentioned, it fits in the level 4 with equal partners. But however, in a co-design project, you will be actually engaging with consumers at all different levels. Like you would be co-designing, but also you would be like having some people in the advisory committee, some people that you will be consulting in focus groups or interviews. So it is likely that you will use all different levels at different times during your co-design project. So these are the basic principles and values of co-design. I think, this is really important for us to embed, like the mindset that we were talking about, like in the challenges, like a couple of you had those challenges that, like there's investigator bias, there is the researcher thinks that the consumer's perspective wouldn't be helpful, and the consumer might think that you are actually exploiting them. So actually the mindset is really, really important in co-design, and just making sure that all these principles and values are embedded within the mindset of both researchers and the consumers is really crucial for the co-design initiative to be successful. I actually have definitions for each of these, but I'm going to skip over that. How am I doing with time, Gopi?
We have time. You can continue.
So is it 15 more minutes for the...
We can run it till 11:10 as well if you have time, no problem.
Okay. So I don't know. Okay. So I just wanted to, like, of all the principles and values, I think I might just touch on the equity, which I have on the slide. So we need to understand that equity is not the same as equality. So sometimes it's like confused. So equality, for example, is giving everyone the same resources or same opportunities. But equity is actually giving people the resources and opportunities they actually need to reach an equal outcome, right? So, so equity is in research is important. Sometimes, like we do not have that equity, and there is no balance of power, and there is poor dynamics, and the marginalized population, the population that are least represented, are like always least represented in research. And if we are actually researching them, then you should have more of them and make allowances for more of them to participate in the research, take part in the research, as well as partner with you in the research. For example, you have to make sure that whatever you're doing is accessible. The materials that you're generating is, so one of the challenges that you guys highlighted was explaining the research question. So that's really important, because like we tend to use lots of jargons when we explain research, and having someone from a consumer with us as co-leading the research actually helps us to disintegrate this like jargons that we use into layperson terms, that then that would actually help reach to a lot of different people from the marginalized community, and then we would be able to partner with them more efficiently. So these are some tips that you can see on the slide. So having someone, for example, if you're working with people with disability, then having a person with disability as co-lead on the team helps to bridge some of these equity issues. And if you're having a co-design team, make sure that more than half of your participants are, like identify as part of the community that you're researching. And peer-to-peer model of engagement is when you use actually the lived experience researcher to do the communication to the other broader community that you're researching. Then it's more efficient than we going and talking to them. And I think I have touched on other points. It is really important that we actually build relationships and maintain them through transparent and open communication, as well as invest time in that. So what can be co-designed? So we could co-design a range of things. So in health systems, co-design has been used to develop models of care, like new treatment pathways, patient information materials, new technology, like changes to physical environment. Like I know a project where they actually consulted patients to redesign their ICU, and new health services. So in the next slide, actually, I have some examples of co-design in healthcare. So, so the if you're actually interested in co-design, how co-design is applied in other health fields, you can go over these references, and it's very really interesting how they have used this, like research methods to have different outcomes. Anyway, so in my role here at UNSW, I recently used co-design methods to develop a new model of care, which actually I have as a case study at the end. But you can see on the slide, you can see how co-design can be used to improve practitioner decision making, practitioner communication skills, leadership skills, implementation of guidelines, and quality improvement. So there is a lot of scope and potential for co-design, and it's something that is really gaining importance in the health research field, and something that we should definitely consider going forward. Okay, and so how does co-design work? What's the co-design process and techniques? So there's like several frameworks on co-design process available online. So the one on the left is a really simplified process from New South Wales Health Agency for Clinical Innovation, and onto the right, it's kind of an expanded version. This is from another agency. I'd like to refer to the first one because it's simple. So here you can see, like in the startup and the engage stage, you could actually frame the project, the research problem, the research questions, build the team, and get ready for the co-design. So that's the first step to co-design. So the first step to co-design is to identify the research problem, the problem that you want to research, and then build your co-design team and get ready for the co-design process. So then once you've done that, you actually you gather experiences, you build understanding by learning from the lived experiences. And then you understand, you make sense of what you have learned, identify the key touch points, and identify what needs to improve as a team of co-design researchers. And then you work on it, you create solutions, you create prototypes, you test, you implement, you evaluate, you learn, you adapt, and then you start again. So it's kind of cyclic, but like maybe you will understand better when I present my example. So this was one of my recent project. Like I said, it was called the Vision for Integrated Pediatric Eye Care Project. So the aim of this project was to co-design a new model of eye care to integrate both primary and tertiary eye care services in New South Wales, to ensure that the children get timely and appropriate eye care at the appropriate setting. So to give you a bit of a background, there's a significant proportion of Australian children with vision disorders, and there is a critical shortage of pediatric ophthalmologists nationwide. So with increased capacity, like with the exceeding service capacity, with the increase in proportion and low ophthalmologists in the hospitals, low numbers of low numbers of ophthalmologists in the hospitals, the waiting times for specialist appointments for especially low risk cases is as long as 12 months. So this is a real problem. As you would know, early intervention is important for children. So our team, so the health system in Australia is a bit different to India. So there's optometrists in New South Wales are not in the hospitals. They are all in independent practices. So the children could be referred to the hospital through optometrists or through GPs or through other health professionals if they think they have a vision problem that has to be seen by an ophthalmologist. And when these children get referred to the hospital, they go through a triage process, and if they are high risk, then they get seen like more urgently, but if they are like low risk referrals, then they are put on the wait list, and this wait list could be like for a long time. So our team here at UNSW did an audit and found that like more than 30% of these children could actually be seen in an optometry clinic, because that's within our scope of practice. So we wanted to create a pathway for these low-risk referrals who are referred to the hospital to be referred back to the community optometrist. So it seems simple and straightforward, but it's not. There's like lots of complexities involved in this. So we had to co-design what this model looks like, what would be the processes that the hospitals will follow. We want to make sure that all these different stakeholders, the ophthalmologists, the optometrists, the orthoptists, as well as the consumers who are the parents and families of children who are seeking care, they're all happy with this new model of care. And we wanted to make sure that we co-design the model itself, like the flow chart, but also the parent facing materials, like what information needs to be shared, how it needs to be shared, how can we actually build trust in this model so that the uptake is better, and what conditions could be suitable for this model, what clinical assessments needs to be done, and how can we partner with other community optometrists. So we have an optometry clinic here at UNSW, but we also envision to partner with other community optometrists. So it was a bit complicated at the start. So we wanted to do a co-design process with consumers, but with all the other stakeholders as well, to make sure that the model that we are developing will actually stand up for success. So what did our CCI look like? So we had, even before we started the project, I mentioned to you about the audit that we did. So we did an audit, we did a needs and assessment. We had like general consumer and stakeholder consultation to engage and align our priorities with their priorities. But then, like when we actually got funding, we had a governance structure, we had a consumer advisory committee, we had a stakeholder steering committee. So the consumer advisory committee, like the name suggests, it's made of consumers, and the stakeholder steering committee, we had all these different eye care professionals involved, representing different professions. And then we have a research committee, which was our the team of researchers. So all these committees work together, like they had different priorities in mind, but they came together with an equal partnership and governance, so we could, like steer the project together. So we used an experience-based co-design toolkit where we employed interviews, focus groups, workshops, and surveys. I'll tell you how we did that. So experience-based co-design is a framework in co-design, and it has like 4 stages. Like it's similar to that stage that we saw earlier, the co-design process. So the first stage is gather perspectives, where we actually try to understand the perspectives of the consumers and the stakeholders, the eye care professionals. So we know what's the current situation and what's their expectations in relation to this model of care that we are developing. And then we analyze those data. Like, so as you can see, this focus groups and interviews are in the consultation stage. So we have just consulted, but like the co-design framework is the one overarching the whole process. So we gathered perspectives, and then we identified key touch points, right? So we have perspectives from the consumers, we have perspectives from the stakeholders, we analyze those data together, we present them regularly to our consumer committee and our steering committee with whom we are actually co-designing. So we identified key touch points together, and then we again shared these findings with our consumers and stakeholders, and we identified through this process what are the key touch points, what are the expectations for this new model of care, how this model of care needs to be designed. And then we developed a prototype which we tested in 4 core design workshops. So core design workshops, so I might have skipped over that. So these are the like the techniques in that is generally used in co-design process, but workshops is the most important one that's that's used more often. So workshops could be like in person or online, and because our consumers were like working parents, we often we only did like online workshops, and also like eye care professionals, they prefer online workshops rather than in-person ones. So this is like kind of a snapshot. I'm not going into the details, but this is a snapshot of the workshop that we conducted. So we had used a collaborative tool called Miro. So we had all these different pages with all these different questions and polls and sticky notes, so they could vote, they could engage with the content, they could like do dot polls, they could help us, like together with the researchers, the consumers in one workshop, and the stakeholders in the other workshop, actually co-designed the model of care. So we co-designed the prototype. Based on this, the prototype was co-designed. So that's the professional workshop one. We co-designed what conditions needs to go in the pathway and so on. And then with this prototype, the researchers took it back, made those changes, and then went back to the co-design workshop participants. So like we had again 2 workshops, one with parents, one with professionals, and we co-designed the model flow chart. The parents kind of co-designed different aspects of the model. Obviously, like you would understand that. So their perspectives are from a parent's perspective. So they helped us co-design the communication preferences, how the appointment letters needs to be, what are the frequently asked questions if we are going to implement this model, how that needs to be answered, and what should go in the website and so on, while the professionals worked on the model's flow chart, the eligibility criteria, the assessment forms, and so on. So at the end of the co-design project, we had developed an extensive document highlighting the model of care. So that was a really valuable process, and we could see the benefit of doing that because it brought all these different consumers and stakeholders on board, and then they were all happy. We actually did an evaluation of this co-design process as well, but I haven't included that in the slide. So these have not been published yet, so please refrain from using that anyway. So that was an example, but so there are some reasons why co-design might not work in your context. So some of the reasons are like, again, timeframes are too tight. You have to complete this by this timeframe. Then if your organization is not ready, if you do not know how to do co-design, if the solution is already decided, then there's no point in doing a co-design. And if it's just tokenistic, then there's no point either. So these are some of the reasons why co-design might not work for some research context or your setting. But there are a lot of other ways to engage with consumers, like I said, on the consumer ladder. So if co-design is not the right fit for your project, just don't throw in the towel completely. There's always something better than nothing. So you can actually use the co-design practices, having those principles and values in mind, using some of those techniques. Without committing it to a full co-design project, you could actually borrow some of these things in the consumer engagement that you do. So the key messages from today's talk is that, consumer and community involvement is crucial for meaningful impact and research translation. It could be done at different levels and at different stages. And the earlier you get the consumers on board, the better. And co-design is a powerful way for consumers, health staff, and researchers to partner to improve health services. But like I said, so just choose whatever works for you within your context. So these are some of the tools and resources that I have used in this presentation, and something that you would find like there's enormous amount of information in these links, and I'm happy to share that with you. So that's the end of my talk. I'll stop sharing.
Thank you so much, Dr. Sheela. Saranya ma'am, do you have comments or do you want to ask something?
No, I was just quite interested in the whole process, because it's like you said, Sheela, it's something that we've all probably done at different levels, not at the level that you're talking about, but not really thought about it as a co-design process at all. And the other thing is, it's interesting to see how policies are made. So this is basically how policy works, isn't it? Working with everybody involved, bringing them all on board, and I can see how much of work goes into it. So very interesting talk. Brilliant talk.
Thanks. So just on that point, like there's this publication which says that there is like around 17 years approximately gap between an evidence and to be translated into policy. I think you might have seen that paper. It's so interesting that, like all these evidences that we know works is actually not being implemented in real life, and it takes like ages. And I think one of the main reasons could be that, the lack of consumer involvement.
Correct.
Yeah.
So I was just thinking about that when you were talking, how we should have actually brought all the stakeholders in the beginning. Then it might have actually driven the process and could have made the policy much quicker. So yeah, very interesting. Very interesting.
Yeah, there's like lots and lots of examples in these links where they have actually used co-design methodology or like a consumer involvement in different levels, and how that has shaped research priorities and outcomes. And it's a big topic. I tried to cut it down, but I quite didn't do a good job. I ran over 1 hour. Sorry about that.
No. This is a brilliant snapshot of what is there, and somebody who is interested is probably going to reach out to you or do some more reading up and then explore this option more. So I'm so glad that you spoke about it today, because I think it's such a valuable perspective to bring into what research, so to speak, and what we all have to do. This is something that can actually limelight optometry as a profession as well, because if you start doing it and people recognize your contribution to the society. That's when the profession is also highlighted. So awesome. Thank you.
It's great. Yeah.
Sorry, Gopi, if you have questions.
Yeah. Before I take up questions, like I thought I'll share two interesting instances. When we were publishing a qualitative paper, there was a from BMJ Open, there is a comment, there was a comment from the reviewer. Did you involve the patient perspective and public aspect in your paper? And we had to put it as a limitation because we did not involve people with that problem. So that's the one. And the next thing is we are actually working as for a postgraduate student at Acchutha. We are working on looking at a compliance towards some from parents' perspective, how the child is using that or not. So we were thinking on some innovative ideas, and I told one of our students, okay, why don't we ask the patient as a stakeholder itself, the parents, get their inputs before you decide what they really want. So whether we thought, okay, we will go with some innovative log sheets or software newly development. So we thought, okay, let's ask the parents. So she's actually asking the parents now. So I think that's the phase of co-designing. So we were not knowing the name, but hereafter, I think henceforth we will use the
It's
term.
just not, yeah. So it's just not asking. So asking could be just consulting. Like if you ask and then leave it there, then it's consulting. If you ask and then keep asking and reporting back to them, it's advisory. But then if you make decisions, share your power with the parents, bring them on board. You don't have to have like, you will have like 100 research participants who are parents, but then you will have like one or two parents who are co-researchers with you on the team, and then whatever decisions you do it in partnership with them. So that's co-design.
So that's the question I had. Like, do we have any minimum number of participants to get involved in the co-design stage?
See that's what I'm saying. Like co-design is a broader term, and then you will do like different types of engagement. Like for my study, for the qualitative study, I had like around 20 people take part in the qualitative study, but in the workshop, I think was, I don't know, I can't remember, 15 people, I think, with two different workshops altogether. But it was kind of an iterative process. Co-design, you can have the same participants over and over again. Like those who took part in the interviews, they continue to take part in the workshops, like developing what you're developing or researching what you're doing. So yeah, like depending on the research context, you will have to adapt. And there is a lot of tools out there. You don't have to reinvent the wheel at all. Like so many tools and so many resources. It's like an ocean out there. And if you need any support from my end, I'm happy to direct you. Or if you want me to collaborate with you on any projects, I'm happy to.
Thank you. Do we have any questions from the
That
participants?
was going to be my next question, actually. So she's answered that. So thanks, Sheela.
I do see Dr. KK on the participants list. Do you others have any questions? Otherwise, we'll close the session. Before I close, I'll share the link for the OCA accreditation C certification in the chat box. Please fill in the questionnaire so that you receive the certificate. Is in the chat box now.
Yeah. So Sheela, Tamil, they say Puli ettadi panja, Puli kutti 16 adi payunnu. Proof. So I must actually say, lot of respect for Kumaran sir always. I can see how much of it has passed on. He must be a very proud father. Very, very happy to see you doing so well.
Thanks. I'm proud daughter as well. Like he achieves more than me.
I have no clue where he gets the energy, man. He's on the go always, and he always wants to learn. So that's something which I absolutely admire. Something that we all should pick up from him.
Yeah. Absolutely.
If there
Thank
are
you so much.
if there are no more questions, let me stop the recording.